Greetings, everyone. I am John Loonsk. I'm the consulting CMIO for APHL, also an adjunct at Johns Hopkins Bloomberg School of Public Health. The work I'm talking about was done in collaboration with Nagesh Bashem, also known to many of you as Dragon, who is the CTO of FHIR LLC and also Caradora. What I'm going to be talking about is electronic case reporting, and specifically how in the light of the COVID-19 situation, we have used FHIR to advance technology solutions to help the country move forward in this regard. But first, a little bit of context. So electronic case reporting is the automated identification of reportable events in electronic health records and their transmission to state and local public health authorities for review and action. The states then send some data in anonymized forms to the Centers for Disease Control and Prevention, but this act of case reporting occurs with state and locals. We were in the process of implementing electronic case reporting when COVID-19 hit the United States. Case reporting is required by law in every state. On your screen are some of the rules that are implemented for the state of California. But every state and territory in the United States has its own rules, and hence some of the complexity of automating this process between the electronic health record in clinical care and the surveillance system in the appropriate public health agency. The data for electronic case reporting are really important for responding to COVID-19 and other public health emergencies. It was implemented with a small number of sites when COVID-19 struck, and it was demonstrating itself as being helpful in the context of providing critical clinical data to public health agencies for outbreak management. The kind of data include patient demographic information that could be used for contact tracing, race and ethnicity data to understand the path of the disease, occupation, pregnancy status, other clinical data that are critical in terms of managing an outbreak. It was functioning well. It was just functioning with a limited number of implementation sites when COVID-19 struck. We had, unfortunately, only a very small number of electronic health record vendors that had implemented a technical solution for COVID-19 case reporting or general, more broad electronic case reporting as well. So it became very clear to us that we needed a solution to move electronic case reporting forward faster, and that became eCR Now. eCR Now has three major elements to it. The first is rapid onboarding, and we have done this with Epic in a number of sites since COVID-19 has hit. And I indicated to you there were only 4 health systems that had implemented eCR at the start. We now have over 2,000 sites that are reporting and doing COVID-19 electronic case reporting on the basis of rapid onboarding in cohorts with many people working together, pulling in the same direction to make this happen. The second element, and the thing that I'm going to talk about mostly today, is the eCR Now FHIR App that we developed as a means of conveying to electronic health records that did not have electronic case reporting capabilities the ability to do electronic case reporting for COVID-19 and do that rapidly. So the eCR Now FHIR App is really a testament to some of the potential of FHIR and the FHIR API moving forward. We had providers who wanted to do COVID-19 reporting. They want to do it because it's the right thing. They also want to do it because there's the opportunity for them to stop the manual processes that are so distracting to them when they're trying to take care of patients. We have public health agencies who, with a few exceptions, are connected to receive electronic case reports, but we did not have eCR capabilities inside of a broad array of electronic health records at the start. So we developed the eCR Now FHIR App, and that app is intended to connect the EHRs using the FHIR API that's out there in the wild to an existing eCR infrastructure that confirms these case reports and routes them to the appropriate public health agencies and surveillance systems. That existing infrastructure is in blue. The placement of the eCR Now app is shown on the top line here in red, and the provider EHRs are arrayed on the left. Essentially what happens is that the provider EHR, in the course of care, records some event. The eCR Now app, acting in the background, checks those trigger codes and determines that something is reportable and communicates that to a shared services platform that then sends it, confirms it is reportable, and sends it on to the appropriate public health agencies when it is indeed a reportable condition. There is also a response transaction called the reportability response that goes back to the patient's chart from which that case report originated. So we had been working on a FHIR app to support electronic case reporting. When COVID-19 hit, we pivoted. We focused the development of that app on specifically providing electronic case reporting now for COVID-19. The app can do broad electronic case reporting, which as of the end of this month will include roughly 89 conditions as well. But most healthcare providers and certainly the public health agencies are focused on COVID-19 eCR right now. The app functions as a background service. It's not intended to have a user interface. We have been seeking to make reporting automated, and we sought to make this app work in that way. We began the work on the app using FHIR subscription as a method for doing that and for triggering on an appropriate data change in the electronic health record. But when we pivoted, we had to look for different launch methods and for different ways of doing this triggering. And what we have settled on are two timed trigger queries that are related to the start of the encounter and after the end of the encounter. And to do that in FHIR with the API that's in the field, which is DSTU 2, maybe some STU 3, and a titration of R4. We did this with launch methods that were able to get the context for the encounter and the patient. That was necessary to identify this triggering activity. So we did that using Smart on FHIR App Launch. We have that approach still implemented, although that suggests the use of some sort of UI. We also have a variant on that, which is Smart on FHIR with a system account that can launch with no UI necessary and can be fully automated as a background process, but still have the patient and the encounter context. And then we have another API-based launch with a system account that can be used for other reasons. Other people considering this activity of launching an app in the context of the patient encounter and the patient have used the ADT stream to do integration at a health system level to filter that stream and look for the encounter events and look for the patient context. We determined that would be too reliant on a substantial amount of integration at each health system level. And what we were trying to do was make an app that could be broadly accessed by different EHR vendors, by different EHR implementers, and be implemented in such a way that it could be readily installed with as little integration as possible. That being said, we have found in the app construct, even in a background services app, a lot of power that can be oriented to meeting the goals of what we're endeavoring here. I will point out that one of the things we're doing is, in terms of this app, is facing the EHR with the FHIR API and facing the rest of that infrastructure I alluded to on that previous slide that is oriented to public health and public health agencies, with a CDA version of the electronic initial case report that we've been using in other implementations. So it is kind of a hybrid app, FHIR on one side, CDA on the other, but because of the app construct, we can validate the outgoing CDA app we can do the mappings that are necessary, and we can actually integrate into the app capabilities to, for example, do direct transport, which is part of the app, and as well as have an interface for XDR transport as well. In the recent FHIR Connectathon, we had a number of successful implementations. We were doing testing of the beta version of this app, and one of the implementations, as you can see on the screen here, was actually with a Cerner production EHR. They had the app for roughly 3 days when they successfully implemented it and demonstrated quite successfully the fact that this kind of technology, using the FHIR API that's in the field, in the wild, can be implemented readily and distributed readily as need be. The app functions, as I said before, on both a series of FHIR queries. 2 of the queries are what we call trigger queries that look at specific data elements and map them against trigger codes that have been identified by public health as representing reportable conditions. That method of triggering is not conclusive that it's reportable because reporting laws are complicated. And so the triggering suggests a high likelihood of reportability. And when there is a match, then we do EICR loading queries. We have over 100 of those queries that access specific data and have implemented, as I alluded to before, in both DST2 or in R4 that can be used by the EHR implementer. These queries themselves can be edited as well to optimize for the particular EHR. The system itself, the app itself, consumes the trigger codes coming from the shared services platform. This is an important part of doing this kind of surveillance because in an outbreak, the trigger codes and the reporting rules actually change quite frequently. So we developed what we call the ERSD, the Electronic Reporting and Surveillance Distribution. It too is a FHIR service. It's a subscription, is based on FHIR, I should say. It is a FHIR service that's based on subscription. It can also be pulled from the shared services platform, but what it allows is a very readily take the trigger code set, which is quite large, and to load it into the app or load it into the EHR with enough ease that it can be accommodated at the health system level on a weekly basis as these codes would require. It is structured around the FHIR plan definition construct that orchestrates the next step reporting activities in association with triggering, development of the payload, transport of the payload, validation, etc. That orchestration is also defined in the FHIR construct and is distributed and is the structure of the distributed ERSD specification. The app itself can be deployed either by the EHR vendor or the health system locally, or it can be cloud hosted and centrally located by the EHR vendor when that matches with their workflows. And the app itself is only launched into the active EHR session. When this is all over, when COVID-19 does end, and it will end, the implementers of the eCR Now app will be able to just change the configuration and switch to full electronic case reporting for the 89 plus conditions that will be available at that time. All in all, we think this was a tremendous FHIR accomplishment to take this kind of infrastructure, to be able to transmit it, convey it to EHR vendors who have now started to commit to the app as a way of them meeting these electronic case reporting needs and do it in an extremely short time frame. Appreciate your attention. Would be happy to answer any questions that may have